is Dr. Dhanalakshmi from the Department of Oral Maxillofacial Surgery, Biology, Dental College and Hospital. Today we are going to discuss about principles of flaps in oral surgery. Principles of flap design. The term flap indicates a section of soft tissue that is outlined by a surgical incision. It carries its own blood supply. It allows surgical access to the underlying tissues and can be replaced in its original position. It can be maintained with sutures and is expected to heal. It is used in oral surgical, periodontic, and endodontic procedures to gain access. The base of the flap must usually be broader than the free margin to preserve an adequate blood supply to prevent ischemic necrosis of entire flap or portions of it. The flap must provide adequate access and visualization of the surgical site without tearing or bruising of the flap and damage to the adjacent structures. The retracting instrument of the flap must rest on healthy bone to avoid trauma so as to provide healing with minimal inflammation, pain, and subsequent scarring of the tissues. There must be enough flap reflection to permit the retractor to hold the flap without tension. The incision should lie towards healthy bone so that after closure the suture lies on solid healthy bone, as incisions over closed dead space tend to break down. The flap should be a full thickness mucoperiosteal flap. This means that the flap includes the surface mucosa, submucosa and periosteum because the periosteum is the primary tissue responsible for bone healing. The flap should be designed to avoid injury to local vital structures in the area of surgery. The vertical releasing incision should be made at an obtuse angle to the horizontal one to have a flap with a broader base with respect to the apex. In this slide, the first picture depicts the basic incision for exodontia is a circular incision that is sufficiently extended to allow access to the surgical site while avoiding excess tension that can tear the flap. The second picture depicts a properly designed surgical flap is wider at its base to ensure adequate blood supply to the margins of the incision. Third picture depicts when access to the more apical region of the alveolus is needed, a vertical releasing incision can be made. The direction of the vertical releasing incision is made in consideration of ensuring adequate blood supply. This table gives small description about summary of flap design considerations. Incision over the bony prominence to be avoided. If it is not avoided, it may lead to tension, dehiscence and delayed healing. Incising through the papilla will lead to dehiscence periodontal defect. Similarly, incision over facial aspect midbone will also lead to dehiscence periodontal defect. Incision not placed over sound bone will lead to collapse and delayed healing. Vertical incision in area of mental foramen may lead to injury to the mental nerve. Lingual releasing incision in posterior mandible will lead to injury to the lingual nerve. Vertical releasing incision in the posterior palate may lead to bleeding, injury to the greater palatine artery or vein. Types of flaps: trapezoidal flap, triangular flap, envelope flap, semilunar flap. Other types of flaps such as flaps with Y incision and I incision, pedicle flaps. Trapezoidal flap. A trapezoidal flap is formed by a horizontal incision along the gingiva and two oblique vertical releasing incisions extending to the buccal vestibule. The vertical releasing incision always extends to the interdental papilla and never to the center of labial or buccal surface of tooth. This ensures the integrity of the gingiva proper because if the incision were to begin at the center of the tooth, contraction after healing would leave cervical area of the tooth exposed. This picture depicts the trapezoidal flap. The trapezoidal flap is formed by horizontal incision along the gingiva with two oblique vertical releasing incision extending to the buccal vestibule. The vertical releasing incision always extends to the interdental papilla and never to the center of the labial or buccal surface of the tooth. Trapezoidal flap is also called as four-corner flap. Why? Because it is an envelope flap with two releasing incisions with four corners. The incision should be extended one tooth anterior and one tooth posterior. Trapezoidal flap is rarely indicated. Advantages of trapezoidal flap are as follows. It provides excellent access. It allows surgery to be performed on one or more teeth, produces no tension in the tissues, allows easy reapproximation of the flap to its original position and hastens the healing process. Disadvantages of the trapezoidal flap is produces a defect in the attached gingiva. So this leads to recession of the gingiva. Next, triangular flap. This flap is the result of an L-shaped incision with a horizontal incision made along the gingival sulcus and a vertical or oblique incision. The vertical incision begins approximately at the vestibular fold and extends to the internal papilla of the gingiva. The triangular flap is performed labially or buccally on both jaws and is indicated in the surgical removal of root tips, small cysts, and episectomies. This picture represents the triangular flap. In this flap, we can see the L-shaped incision with the horizontal incision along the gingival sulcus and a vertical oblique incision extending from the vestibular fold to the interdental papilla of the gingiva. Triangular flap is also called as three-corner flap. Why? Because it is an envelope flap with one releasing incision with three corners. Here, in this flap also, the incision should be extended one tooth anterior and one tooth posterior. It gives a greater access in apical direction, especially in the posterior aspect of the mouth. Advantages of triangular flap. It ensures an adequate blood supply, satisfactory visualization, very good stability and reapproximation. It is easily modified with a small releasing incision or an additional vertical incision or even lengthening of the horizontal incision. Disadvantages of the triangular flap is limited access to the long roots, tension is created when the flap is held with the retractor and it causes a defect in the attached gingiva. Next, we are going to see about envelope flap. This type of flap is the result of an extended horizontal incision along the cervical lines of the teeth. The incision is made in the gingival sulcus and extends along 4 or 5 teeth. The tissue connected to the cervical lines of these teeth and the interdental papilla is thus free. The envelope flap is used for surgery of incisors, molars, premolars on the labial or buccal and palatal or lingual surfaces and is usually indicated when the surgical procedure involves the cervical lines of the teeth. This picture depicts the envelope flap. In this picture, we can see the incision is made in the gingival sulcus and it extends along 4 or 5 teeth. The tissue attached to the teeth and the interdental papilla is thus free. In envelope flap, the incision should be extended 2 teeth anterior and 1 teeth posterior. In case of edentulous ridges, the incision should be made at the crest of the ridge for the removal of mandibular torus. Advantage of envelope flap is that avoidance of vertical incision and easy reapproximation to original position. Disadvantages are difficult reflection, mainly palatally, great tension with the risk of the ends tearing, limited visualization in episectomies, limited access, possibility of injury of palatal vessels and nerves, defect of attached gingiva. Next, we are going to see flap resulting from Y-shaped incision. An incision is made along the midline of palate as well as two anterolateral incisions which are anterior to the canines. This type of flap is indicated in surgical procedures involving the removal of small exostoses. Next, we are going to see about flap resulting from I-shaped incision. This type of flap is used in larger exostoses and is basically an extension of Y-shaped incision. The difference is that two more posterolateral incisions are made which are necessary for adequate access to the surgical field. This flap is designed such that major branches of the gluteal palatine artery are not severed. This picture depicts the Y-shaped and I-shaped incision. Next, we are going to see semilunar flap. This flap is a result of a curved incision which begins just beneath the vestibular fold and has a bow-shaped course with convex part towards the attached gingiva. The lowest point of the incision must be at least 0.5 cm from the gingival margin so that the blood supply is not compromised. Each end of the incision must extend at least one tooth over on each side of the area of bone removal. The semilunar flap is used in episectomies and removal of small cysts and root tips. This picture shows the semilunar flap. The flap is a result of a curved incision which begins just beneath the vestibular fold and has a bow-shaped course with a convex part towards the attached gingiva. The lower part of the incision must be at least 0.5 mm from the gingival margin. One more pictorial representation of the semilunar flap. In this picture, we can see each end of the incision extending at least one tooth over on each side of the area of bone removal. Semilunar flap is easy to approach the root apex. It avoids trauma to the papilla, gingival margin. It is useful for periapical surgery of a limited extent. It should not cross major prominences, example, canine eminence. Advantages of semilunar flap is that small incision and easy reflection, no recession of gingiva around the prosthetic restoration, no intervention at the periodontium, easier oral hygiene compared to other types of flaps. Disadvantages of seminar flap is that possibility of incision being performed right over the bone lesion due to miscalculation, scarring mainly in the anterior area, difficulty of reapproximation and suturing due to the absence of specific reference points, limited access and visualization, tendency to tear. Next, we are going to see pedicle flaps. Pedicle flaps can be mobilized from one area and then rotated to fill a soft tissue defect in another area. The three main types of pedicle flaps used for closure of oroantral communication are buccal, palatal, bridge flaps. This picture represents the buccal pedicle flap and palatal pedicle flap. These techniques are suitable for closure of oroantral communication. In this picture, we can see pedicle bridge flap, which are used for oroantral communication closure. In this slide, we are going to see about what are all the complications involved in the principles of flap design. They are flap necrosis, flap dehiscence, flap tearing, and injury to local structures. First, we are going to discuss about flap necrosis. How to avoid flap necrosis. The base of the flap should be more than the free margin to preserve an adequate blood supply unless there is a major artery is present in the base. Width of the base should be twice the length of the flap. Less critical in oral cavity, but length should be less than the width. A long straight incision with adequate flap reflection heals more rapidly than a short torn incision. An axial blood supply in the base. Hold the flap with a retractor resting on intact bone to prevent tension. Next, we are going to discuss about flap dehiscence. The incision must be made over intact bone. If the pathologic condition has eroded the buccocortical plate, the incision must be at least 6 or 8 mm away from it. The incision is 6 to 8 mm away from the bony defect created by the surgery. Gently handle the flap edges. Do not place the flap under tension. Do not cross bony prominences. Example, canine eminence. In this slide, the first picture shows the depiction of incision being placed over intact bone, whereas the second picture shows the incision being placed away from the intact bone. This may lead to tension when the flap is elevated, which in turn may end up in flap dehiscence. Next, we are going to see about flap tearing, how to avoid flap tearing. In case of envelope flaps, incision should be made around the necks of several teeth, it extending at least 2 teeth anterior and 1 tooth posterior. If it doesn't provide sufficient access, vertical oblique releasing incisions can be given, extending 1 tooth anterior and 1 tooth posterior. And it should be started at the line angle of a tooth, and it should be carried obliquely apically to the into the unattached gingiva. If it crosses the papilla, it may lead to localized periodontal problems. Lastly, we are going to see about injury to the local structures. In case of mandible, when the vertical incision is placed in the area of mental foramen, it may lead to injury to the mental nerve, whereas lingual releasing incision in the posterior mandible may lead to injury to the lingual nerve. In case of maxilla, a vertical releasing incision placed in the posterior palate may lead to bleeding of greater parotid artery or vein. These are my references. Thank you for your kind attention.